let's now move to where we're going in the future. You know, certainly the HER2 biology lends itself to a lot of strategies. We've seen a lot of data in the neoadjuvant and advanced setting. Joyce, perhaps you can review where we are with the addition of lapatinib. We think that that's sort of the leading edge of how we're going to improve the outcomes in the adjuvant setting.
Well, I was very encouraged with all of the preoperative lapatinib and trastuzumab combination trials. I think the NeoAlto was the largest and perhaps the most definitive, but it was bolstered by 2 or 3 other studies that all showed about a 50% improvement in the pathologic complete response rate with the addition of the lapatinib to the trastuzumab. So clearly the doublet is better than either single agent alone, particularly impressive in the ER-negative population. And we saw that as well in the TEACH trial, where patients had not had the opportunity to receive the adjuvant trastuzumab because they were diagnosed before 2005, and then they were randomized to the lapatinib versus placebo for a year. And the trial was borderline statistically significant. It trended, but didn't make the statistical. But on the ER-negative population, and importantly, the centrally reviewed HER2 positive, population, because 21% were false negatives, But anyway, it was a positive trial, but it was all the benefit was in the ER-negative group. And so it's very important, too, because we know that the path-CR translates into improved disease-free survival in your ER-negative, HER2 positive. So it's kind of like the elephant in the room waiting for the ALTO data, because you've got the high-risk preoperative patient, and she's ER-negative. And we know she's going to have a higher path-CR rate. And we know that that translates into disease-free survival. Now, I'm waiting for the ALTO data. I'm waiting. I'm not using the lapatinib preoperatively, but I wonder if she doesn't have a robust response right away with preoperative chemotherapy and trastuzumab, I'm considering adding it, because those data are quite compelling, the preoperative lapatinib data.
Do you think it'll get confused by all of the other products that are coming along in that field as well? Because the toxicity still on the lapatinib's, fairly significant for patients.
Especially with the chemo part, sure.
Right.
I think we're going to need to wait and see, how clearly it is more toxic, although the part where without the chemo, the trastuzumab lapatinib seems to be pretty well tolerated. And of course, the other area that we're all interested in, and we'll cover the pertuzumab and trastuzumab data later when we talk about the metastatic setting, but obviously based on that result, we're interested in the early stage. And Linda, can you update us on where we are in looking at that combination in the early stage setting?
Yes, the Affinity trial is open and accruing, in which patients receive chemotherapy and trastuzumab plus or minus pertuzumab. And we don't have it open, but we have been referring patients to other centers in New York that have it, because I think based on the data we've seen in the metastatic setting, I think the expectation, we hope, of course, is that we will be able to improve the outcome with HER2 positive breast cancer patients.
I think we all look forward to that, and as I said earlier, there are many avenues for HER2 targeted therapies.